Okay.
All right, so I'm going to show you guys how to do a physical assessment head to toe. First, I would obviously wash my hands. I'm going to use some hand sanitizer here. I would provide for privacy, walk into the room, check orders. Hello, I'm Erin. I'm going to be your nurse today. Can you tell me your name?
Jennifer Stewart.
Nice to meet you, Jennifer. Can you tell me what the day is today?
Today is February 11th.
It's close.
12th.
Okay. And what year is it?
It's 2013.
Okay. So I would go by starting with the day, and because she was able to actually figure it out, then I would observe that she was oriented to time. And where are you at right now?
I'm in the Clinton Technical Hospital.
Okay. And in what town?
In Clinton, Missouri.
All right. Now, if she wasn't oriented at that point, I could go even farther and see if she knew where she was at in the country. So why don't you go ahead and lay back for me, and I'm going to take my pen light and have her look straight up at the ceiling. If there's a bright light above us, then we wouldn't have her look straight up at the ceiling, but just somewhere that I can have her looking at the same light. So I'm going to turn on my light and flick it into her eyes to observe the constriction and dilation of her pupils. And they look good. And then also, as I'm walking in, I've observed her skin color, whether it's pink, pale, blue. I've observed her facial features to make sure that they're not drooping on any side, or if she has any lip droop or anything. And then also the way she's talked to me, that she's not mumbling, slurring her speech or anything like that. I would also do her vital signs at some point, whether at the beginning or the end, but we'll defer that because you guys know how to do that already. So, can you tell me if you're hurting anywhere?
I am not.
No pain, okay. I like to do that at the beginning just because if she's hurting and then it takes me, 12 minutes or whatever to do her assessment, then she has to sit there for 12 minutes with hurting and having some pain. If she did say that she was having pain, I would ask her where the pain was at, how it felt. I might look at that area and then also get a scale on 0 to 10. I usually say to her, if she were to say that she had pain, I would say, well, 0 being no pain and 10 being the worst pain that you've ever felt, like a dog is gnawing on your foot right now, what would you rate that? That gives the patient something to gauge their pain scale on, because most patients have a hard time kind of gauging just a number. Okay, so now I'm going to start with my physical assessment, and I would clean off my stethoscope in front of the patient as well as wash my hands in front of the patient as well. We're going to do lung sounds, and I obviously know that by looking at her, I don't see that she is having trouble breathing. She's not got any labored breathing, she's not got any chest retractions, nasal flaring, so her assessment right now is regular or unlabored breathing. So I'm going to listen in the front underneath her clothing and ask her to take a big breath for me, in and out. Okay, and I hear clear sounds there. I want to do 4 in the front. Okay, that all sounded clear. Now, it's a little trick that I like to do. Go ahead and squeeze my fingers and then pull up on me. That tells me a couple things. I've assessed her grips to know that they're equal and strong, and then having her pull up on my hands also lets me know what her strength is. If she can't pull up and I have to turn her over to listen to her back, then I know that she's kind of weak. Okay, let me pull your hair over. I have to expose your back here, Jennifer. That's okay. Now on the back side, posteriorly, you're going to listen to 6 spots, and I like to do it in a J on each side. So I'm going to do 2 here, about 2 here, and you never want to listen over the scapula because then you can't hear anything really. And then 2 on the bases. So you really want to always get down to the bases. This becomes a problem. It's not a problem for me with Jennifer because she can sit up easily, but when you have a patient that cannot turn it's harder to listen to those sounds. So again, going underneath the clothing here. Let me put this down here so I can get over easier. Underneath the clothing here, so I can listen really accurately. Big breath for me. And then kind of going in a back and forth pattern. Down really far over here on the lungs. Okay. And at this point too, I can do the right side, the right middle lobe, right under her armpit here, kind of where the bra strap really hangs. Okay, all sounds clear there. If she were to have any different kinds of abnormal lung sounds, then you can listen to more sites on her back and front. Okay, go ahead and lay back for me. So now I'm going to listen to her heart sounds. And we start over here on the right side, listening to the aortic sounds. And right now, I'm just listening for sound. Sounds good. Over here in pulmonic. And go back down in here on the tricuspid. Okay, those all sound regular to me. There's no extra sounds. It doesn't sound like a swooshing sound, like a murmur or anything. Now I'm going to go under here and probably have her move her bra strap for me. If you can lift that up for me. And then that's where you're going to listen to the apical pulse, and that's the mitral sound. And at the same time, I can feel for her radial pulse. And count her pulse. Okay, so I would go for a full minute to get the apical pulse at that point. And then again listening for if it's a regular rate, if she has a murmur or any extra sounds within her heart rate. And then by feeling her radial pulse at the same time, number one, it helps me to be able to listen to her heart rate if she has coarse lungs or hyperactive bowel sounds. That helps me to listen to her heart. But also it lets me know that her radial pulse and her apical pulse are in the same, they're both regular, they're beating at the same time. So those are good to know. So then I'd go ahead and feel on her other radial pulse, make sure that it is strong and beating regularly. Then I can take and feel or look at her cap refills, and she's got some nail polish on, so if I want to go on the tips of her fingers, you want it to be brisk or less than 3 seconds for it to turn back to the red color. And then I can do skin turgor here on her since she's young, and it's elastic because it's going straight back to just flat. Or if in the elderly, you can do it here as well. And you can look at skin color. If you feel that they're jaundiced, you could press their skin at their chest, and if they turn yellow or blue or don't turn back to the nice pink color that Jennifer is, then we would know that she would have some issues there. Okay, so now we're going to go to her abdomen, and I'm going to look at it first, and you always then, after looking at it, sometimes you might see some peristaltic waves just by looking at it. Sometimes you might see an incision or a hernia sticking out. So it's good to observe it, and then you want to auscultate next. You want to listen to it before you palpate. So I don't want to touch her stomach until I listen. So I'm going to listen, and I should really pretty much right off the bat hear a little bit of bowel sounds. Sometimes it takes a little bit longer to hear something, so you have to wait and hear it. If you really are not hearing any bowel sounds at all, you have to wait 5 minutes before you can call it absent. And then I would always have another nurse come and listen as well. Then you go from that side and you make like a square, listening. If you're not hearing it kind of right off the bat, but you hear a few, then I would call it hypoactive. If you're hearing it right off the bat and it's non-stop, then it's hyperactive. Okay, so you go in that square pattern there. From there, I'm going to palpate, and you want to deeply palpate the stomach because you want to feel whether there's a mass, hernia, if you feel it, if she has any pain, and you want to make sure to get really low because they're going to, sometimes females especially, may have quite a bit of pelvic pain that you may not feel if you only stay up here. So you just kind of go in this and you say, are you having any pain? Well, I do that. Okay. At this point, this triggers me to remember to ask, well, when was your last bowel movement? Yesterday. And was it normal? Did you have diarrhea, constipation? Normal. No blood or anything noted in it. Okay. Also, at that point, you can ask, how is it, are you having any problem peeing? Okay, no odors, or is it burning or anything?
Not at all.
Okay, so that gets those assessments out of the way, and it reminds me to do that while I'm in that area. Now we travel down, and most of the time your patients are going to have gowns on, so you can assess their legs as you're coming down. But if not, you'd at least get their legs, their feet. And you want to take off their socks completely so that you can observe their toes and make sure that they don't have any issues, ulcers in between their toes, and then also their heels. You want to be looking at their heels, especially in the elderly, to make sure they don't have any sores on their heels. Then you come down and you're going to be observing for edema or swelling in the ankles, feet, and she's got a little bit of a sock line, but I wouldn't really call that edema. And then you feel for pedal pulses together. You want to kind of go from the top, you feel that bone there, and it kind of drops you into a spot. And sometimes you can feel it really easily because they're bounding, or sometimes you have to take a little bit to find it. You can usually find one, and then you can search for the other one. This is where it should usually be. Sometimes you have to find it on different people and just search around. After that, after this assessment, then you would have them get up and you would observe them through the day as they're walking to assess for that. Observe them for their urine later on when they void or have a bowel movement, then you would observe that and chart that additionally. If she had oxygen on or an IV, I would look at that as well, or any drains or incisions or anything like that. So, can I get you anything else, Jennifer?
No, that's
All
all
right.
right.
Then you'd pull up your side rail and put the bed down. Wash your hands. Make sure the call light is right in front of her or with her, and make her comfortable. That's it.